Good evening, and thank you for joining us for today's webinar. I just wanted to go over a couple of housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through audio, please note the Q&A function on your screen. If you have a question that is not addressed in the presentation, feel free to submit it through the Q&A feature, and our presenters will try to address as many as possible at the end. Also, today's webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's live. It is now my pleasure to introduce our presenters for this evening. Dr. Henry Vucetich and Dr. Patrick McIntyre are interventional pain management physicians at the UH Lake Som Health Center in Willoughby. Their special medical interests include back and spine disorders, joint pain, nerve block, neuropathy, neck pain, pain management, and many others. I will now turn it over to them.
Thank you, Amanda, and thank you for everybody attending. We appreciate you spending a little bit of time with us, learning about something that Dr. McIntyre are very passionate about. In this day and age, in the year 2021, it's pretty exciting where our specialty is going, and there are so many new great options for patients who suffer from acute pain or chronic pain, and getting the word out to our patients across the area is the best way to educate you all. I just want to set a little bit of an agenda of what we're going to be talking about over the next 20 to 30 minutes before we start taking any questions from you all. And so our topic today, we're really going to focus on something called neuromodulation. And I'm going to go over a little brief explanation of what that is and how we can apply it to helping patients with pain. We're going to talk about what conditions can be treated with this therapy, and also how it has advanced. As you'll see, neuromodulation for the treatment of chronic pain has been around since the late 1960s and has been implanted in patients, since the early 2000s at a higher frequency. So a lot of you may have met a patient who's had a device like this. However, the technology is constantly evolving, and where we're at today versus 3 years ago, 5 years ago, and 10 years ago is pretty amazing. And the outcomes that we're getting and what the patient experience is like is definitely different than a family member, a friend, or a next door neighbor who had a device that was, say, put in them 10 years ago, and it just wasn't effective. As a specialty and as an industry that develops and invents, it's kudos to the people who do these things. It's really been incredible about how we really are helping people return to better quality of life with these devices. And then what are the different types of neuromodulation? I think it's really important that Dr. McIntyre kind of explain what are the different options that do exist, and are they permanently put in? Are they not permanently put in? Are they only in for a short period of time? Do they only target one area? Do they target a large area of our body? And so I think it's important to know that there are definitely options out there where you thought may not have been something that would be for you. And then also at the very end, we want to talk about what's the patient experience like. You can sit here and learn, but what's it going to be for me? If I make an appointment with an interventional pain doctor and I am a candidate for one of these therapies, how do I get processed through it? Is it long? Am I going to be, have a lot of pain? Are the procedures painful for me? What does that look like? And is it done under x-rays? Is it done under ultrasound? Am I awake? Am I asleep? How complicated does this get? And we hope that we can give you a basic general understanding about the use of neuromodulation. And I want to make a point, very early on, and I'm sure Dr. McIntyre will kind of echo this point, that by no means are we a replacement for surgical intervention. Our surgical brothers and sisters who help patients and do back surgery and joint replacement and shoulder surgeries, those are always extremely important. However, sometimes those aren't options for patients to undergo. And so that is where our specialty can come in with the use of this new technology. So neuromodulation is a therapy where we use energy or electricity, or sometimes a medication, to modulate or change the behavior of a nerve. And so it's not only used for pain. Actually, this technology is used for a lot of things in the human body. For instance, for patients with spinal cord injuries, there are systems that get implanted in people's arms per se, or their legs, where an electrical impulse will be sent to contract a muscle so that you can move a hand, you could lift a shoulder, you could stand up or stand down. So neuromodulation is used across the board to help patients. Specifically for us, we use it on a day-to-day basis to help patients with chronic pain. And this is not a new thing, not even since 1967. And you may have seen funny cartoons in the newspaper of ancient Greeks sitting around a pool and a guy putting his foot in a pool being electrocuted by an electric eel. Lo and behold, those ancient Greeks didn't realize that they were doing something very intelligent by using electricity to control pain. It probably wasn't the most comfortable thing for those ancient Greeks, and the way that we apply it is obviously a lot more advanced, but this has been around for a long time, and physicians and healers across cultures have been using this idea of neuromodulation to help patients. And like I think I had mentioned earlier, where we're at with chronic pain, it all started in Cleveland, and it's something we should all really be proud of. Dr. Shealy on the campus of Case Western published the first paper in the late 1960s. There's a great story that he walked down Euclid Avenue to a jewelry store to buy some platinum to make the very first contacts on a lead so that he could apply electricity to the spinal cord or to a nerve in order to achieve pain relief. And that has just basically snowballed over the last 50 years into a really enormous industry and a therapy where thousands of people in this country every year have access to it, but hundreds of thousands of people around the world are their chronic pain is being treated with these devices. And to note, some of the most famous people who develop and invent come from the campus of Case Western with PhDs in spinal cord stimulation that all started here in Cleveland. So there are different types of neuromodulation that we're going to talk about this afternoon very briefly, because if we talked about each of these that you see down here below, this could be a 3-hour webinar, which most of you would probably log off in about 32.5 minutes. So we want to give you a basic kind of brief understanding. The first one that we're going to be talking about is spinal cord stimulation, which is the one that's been around the longest and is probably the one that most people you may know or know somebody who has a device like this. The second bullet point that you see down there, something called dorsal root ganglion stimulation, a little bit of a newer application therapy that's been around since about 2015. However, when applied to the right patient, can be better than anything that we've studied out there, injection-wise, therapy-wise, or medication-wise. And then finally, at the very bottom there, something called peripheral nerve stimulation, which is exactly what it sounds like. We are going to apply some type of medication or energy to a peripheral nerve and in order to achieve pain relief. So what are some common conditions that we may use neuromodulation or some of these devices to treat you with? So as you can see, and this is just a few of them that I came up with when creating this presentation. So things that people may normally expect are back pain or leg pain after back surgery. We call it, lumbar post-laminectomy syndrome or failed back surgery syndrome. We all kind of hate that term because it kind of states that the surgeon didn't do their job, and that's untrue. And so that terminology is definitely changing, and we never want to say that a surgery failed. Surgeries, when they go and they fix something that needs to be fixed, that doesn't mean successful. But if pain exists beyond that, it definitely can happen. And I'm sure everybody has known or met somebody where they may have some of that. And then neuropathies. A lot of people will get neuropathies in their feet or their hands or in their lower extremities and their knees. One of the most common ones that we know about is diabetic neuropathy. And interestingly enough, over this summer in June of 2021, there was great research that was published in the Journal of American Medicine, JAMA, that showed that spinal cord stimulation was the single best therapy that's ever been studied for the treatment of neuropathy, specifically painful diabetic neuropathy. and has an FDA indication for it now. So again, very exciting things, conditions that are extremely hard to treat. So as you know, the title of our slides was spine and joint pain, but the application of this is really across the board when it comes to talking about pain, and those pains are going to be involved with nerves. So typically, and we'll explain a little bit more about that. And Dr. McIntyre will get to that when he talks about peripheral nerve stimulation. Some other things are chronic back pain from damaged lumbar discs, pain after shingles. If anybody has ever had shingles rash, when it erupts, it's painful, but there is a condition called post-herpetic neuralgia, big long term, that means pain after shingles, and it's often in the distribution, around the chest or down the arm or across the buttocks, that can be around forever. That nerve has been permanently damaged or affected by that virus infection, and can be extremely painful for patients. Another interesting condition called complex regional pain syndrome, and there's two types. This often occurs after people have some type of injury to an ankle, a knee, a leg, or an upper extremity, a hand, or a wrist. And sometimes there's an identified nerve that has been injured, and sometimes there hasn't. And this also can happen after extremity surgery that we see. And there's a very specific regimen of treatment that Dr. McIntyre and I use to help patients with this condition. However, there are therapies that can be used to help control the pain and aid the patients through their rehab when they're overcoming this condition. Some other things that you'll see: degenerative disc disease, sciatica. And then some other things that you may not think of this device being helpful for is chronic knee pain before or after surgeries, chronic shoulder pain before or after surgeries, chronic ankle pain before or after surgeries, and chronic low back pain, even before or after surgeries. But it also, in these things, has to be the really correct patient. So just because you have back pain or knee pain, that doesn't mean you're a candidate for this device. It takes specific evaluation, like a physician like Dr. McIntyre and I, to determine where's the source of the pain coming from, and can one of these devices or therapies be used to help treat your pain. And again, I want to be very clear, we are not trying to replace surgical intervention or a surgeon's ability to fix a pathological issue, a tear or herniated disc. But this is a candidate sometimes when people are not candidates for an invasive procedure like that. So as I had mentioned earlier, what are the advancements? Because, at this point, over 100 or 200,000 of these devices have been implanted, and you may have met somebody with this device. And when people come in and they talk to us, the initial thing that we get is, oh, this is an implanted TENS unit. And I want to make very clear, this is not an implanted TENS unit. I tell patients that a TENS unit is the 1983 Ford Escort, and these devices are the $3 million Ferrari. The technology and advancement and what these devices can do is light years away, and how the two systems work and the basis and the mechanism of action are kind of totally two different things. And with TENS units, right, everybody feels a tingling sensation where you put those patches, if you've ever worn one before. But that's not necessarily what a patient experiences now with these devices. And yes, for the first 40 years of stimulation, people felt a tingling, what we call paresthesia. And that's probably where this implanted TENS unit term came from. But we've definitely have moved away from that. And specifically in 2016, huge groundbreaking research came out where everything was kind of changed in this therapy. And we now give patients something called silent stimulation or sub-perception. You are unable to perceive that the system is actually on unless you look at your remote control, but also feel your pain level coming down. So if you can kind of imagine, it was a huge paradigm shift for all of us in how we practice. But patients really love this, because what it is they didn't have to replace one experience, pain, for another one, a pleasant kind of massaging, tingling sensation. It was just that their pain levels were coming down, right? They turn the system on, they go live life. And that's really what we want. Dr. McIntyre, we strive every day to get people to graduate from pain management practice. We do not want you to be in our practice for many years and see you over and over again. We want you all to, have a therapy that gets you out of our doors and go back to living life and doing the things that you want to do. Some other advancements that we found are rechargeable and non-rechargeable batteries. So 2004, first rechargeable battery came about. That was a huge groundbreaking thing because that means that batteries could last longer. The current battery systems we have last about 10 or 12 years, and patients could charge every 3 days, every 10 days. I have patients that charge every 10 days. The efficiencies of these systems have become pretty incredible, and they give you a time you maybe have to charge an hour every 2 weeks for your system to be functional with some of these newer things. However, there are non-rechargeable batteries, and the technology of non-rechargeables has also increased, where we have batteries that last 3 years, 5 years, and in certain instances with certain very low energy programming can last up to 10 years for a patient. And you don't have to worry about necessarily, reaching around to charge something. If you have a bad shoulder, reaching back to put a charger on may be challenging for you. And then around the same time, 2015, 2016, dorsal root ganglion stimulation came out. So what's that? It's a really specific area along our spinal cord. So if you consider it, there's the spinal cord itself, which is attached to the brain. And then you have all these little branches that come off and exit the spine. And that's what goes down into our legs, our arms, our abdomen, and branch off. And that's how our muscles contract. And that's how we feel. But before they go out, there's something called the dorsal root ganglion, which is a little collection of nerves and synapses. And it's kind of like basically a communication center. So if you think about your cell phone systems, right? We always see antennas all over the state of Ohio, and then there might be one big major hub of communication. So you kind of want to think of these as these little antennas that are located up that are in charge of a specific area to your body. And some of them kind of crosstalk, whether they're above and below each other. But the ability to stimulate one individual one allowed us to only get pain relief in a really small area, say of a foot or a knee, or say somebody's groin that had, maybe a trapped nerve after an inguinal hernia surgery and they have some groin pain. So our ability to capture that and really treat it at a very high level came along with this system. And then this idea of traditional success and high responders, which is very, very exciting. Traditional success with spinal cord stimulation, if you look at the literature for 40 years, and if you look at what the insurance mark is that we want a minimum of a 50% reduction in pain. However, what we're seeing with today's devices is this idea of high responders. So these devices are seeing people who have a minimum of 80% reduction in pain. And that is not a small portion of the people studied, it's a majority of the people studied. So as you can see, technological advances have allowed us to definitely capture patients' pain as long as they are the appropriate patient. And then finally, peripheral nerve stimulation. That has been around almost as long as spinal cord stimulation. However, it definitely has not been as developed well as some of these other systems. However, more recently, within the last 3 to 5 years, we have some wonderful new pieces of technology. So we've kind of gone from here to here and really isolating some really interesting areas where we really didn't have an option for patients. And Dr. McIntyre will get a little bit more into that for you. So spinal cord stimulation, again, just some kind of brief overview. Small silicone leads are placed into the epidural space. And I always say epidural space is kind of like two sandwich bags put together. It's a potential space and it surrounds all the nerves and discs in our back from the top of our head all the way down to the bottom of our tailbone. And so if we can put something in that space, what it allows us to do is to get close to structures so that we can stimulate them, but we won't, it prevents us from harming them in certain ways or having to be in the spinal fluid itself. So it's kind of a safety area zone for us to provide therapies and treatments. And then once these leads are in place, they are attached to an energy source and a very intelligent computer, and then energy or electricity is used to manipulate the signals of pain being transmitted up the spinal cord from the periphery, from the back, from the legs, from the knees, and turn the systems on. Pain levels go down, turn the systems off. At some point, the pain levels will rise because it's changing our perception. And it's kind of a different way to think about things, because some conditions are treatable, some conditions are curable. And I had this conversation with my patients. A lot of times there are certain pain conditions that we can only provide a treatment for, to improve a quality of life. And you can see here at the bottom of the slide, this is an example of what spinal cord stimulator leads look like. This is an X-ray of a patient of mine. And these are two leads that are placed side by side, and each of these little black dots, these are the contacts which apply an energy source to help control pain. And then over here is just a basic brief cartoon of what this device looks like. And you may think, hey, this looks like a pacemaker. And yes, these look identical to pacemakers. All the companies that make pacemakers make spinal cord stimulators. The cans or the device itself looks identical. The leads almost look identical themselves. And I've heard physicians give great talks about, when your heart has a bad rhythm to it, you put a pacemaker in, you apply electricity to the heart to get it back in rhythm. So when we have chronic pain, we can do the same thing with the spinal cord, right? There are bad signals being sent from damaged nerves. And if we apply electricity to it, we can smooth out those signals to create less pain. So the next one I want to speak about is this idea of dorsal root ganglion stimulation. Again, not too far off, about 6 years ago. But what it was great is that it allows us to provide really specific areas of pain, like say the top of the foot, the bottom of the foot, just the knee, maybe around the hip a little bit, just the buttock. With other forms of stimulation, we were getting this kind of like more global stimulation patterns. Now, this is not for everybody. Again, you have to be the very right candidate for it. And it is only FDA approved for what you see down here: complex regional pain syndrome, type 1, or causalgia, which is type 2, which means that there's chronic pain after a nerve has been specifically damaged. So this is a really small subset of our patients. However, the patients who are candidates for this therapy do extremely well. And next, I'm going to hand it over to Dr. McIntyre, and he's going to give us a little bit of information about peripheral nerve stimulation and the patient journey.
Good evening, everybody. Thank you, Dr. Vucenic. That was excellent. So I'll discuss peripheral nerve stimulation, the mechanism of action, the way peripheral nerve stimulation works. It's the same as spinal cord stimulation and dorsal root stimulation. Basically, we're applying low-level electrical current to modulate, to change the way the nerves send their signals. However, the difference is we are addressing one or two peripheral nerves. So this would be for something in the arms or the legs, and in some cases, the low back. We'll discuss that in a moment. So we're placing the leads that are designed specifically for these peripheral nerves next to, very, very close to, or on these particular nerves. In the past, before the last, say, 5 years or so, what we tried to do for people with such issues is use the spinal cord stimulator leads. They just weren't designed properly for the use in the periphery. So that technique largely failed and was abandoned pretty quickly. So thankfully, industry recognized that and designed these devices for us to offer our patients. And because of that, this procedure is very safe and it's much easier to perform, and patients do quite well. We can treat shoulder pain, we can treat knee pain, we've addressed ankle issues, foot pain, the hip, hands, wrists. But again, this technique does not replace the need for an operation. This is for people who have had an operation and unfortunately they're still experiencing some neuropathic pain, or the patient is just not a candidate for an operation. We've done this for people with severe osteoarthritis of the shoulder who just had too many health issues that they just could not tolerate the anesthetic and the surgery and the rehab after. And we've been able to reduce their pain. Or for people who've had knee replacement, I know this doesn't happen that often, but people who've had knee replacement and they're still having some pain in their knee, we've been able to reduce their pain by placing one of these peripheral nerve stimulators next to a nerve just above the knee. So there are different types of these devices. There are temporary devices that are implanted for 60 days. There's one particular company called SPR, which is based on the east side of Cleveland, that was started by a woman named Maria Bennett, who has been in the news recently for winning some awards in innovation. She had a fantastic idea, which was instead of implanting a device permanently, she wondered if people could get long-term relief with a temporary lead. And as it turned out, she was right. She found that placing one of these peripheral nerve stimulator leads next to one of these peripheral nerves for 60 days could provide up to 1 year of relief. She studied people, stroke victims with shoulder pain, and the vast majority of these people had a year or more of very good relief of their shoulder pain. So we've been able to apply that for not only post-stroke victims with shoulder pain, but people with osteoarthritis or people with other conditions that have this neuropathic pain in the periphery. There are also some permanent devices as well, where we implant a wire under the skin with a transmitter, and then the patient is given an external battery. So the device is not running constantly, but the patient can apply the battery to the skin over the transmitter and use the device as needed, which is really have been a fantastic treatment for people. The goal, of course, is to reduce pain, to improve function. So, physical therapy, gentle chiropractic treatments, acupuncture, exercise, these things are still in play. We want the patient to feel better so that they can live a more active life. Medications can still be part of the treatment plan. We take a multimodal approach with our patients. The goal is with these devices is to reduce their pain, improve function, so that people can have better quality of life. The patient journey starts with a consultation. If someone is experiencing chronic pain and wants to be evaluated for one of our treatments, whether it's being sent to a physical therapist or obtaining a surgical consultation with one of our surgical colleagues, or a neuropathic pain medication might help, or if it's something that might benefit from neuromodulation, the journey starts with a consultation with someone like Dr. Vucetich or myself. In some cases, some insurance companies and some devices would require a psychological evaluation prior to proceeding with the neuromodulation therapy. This is for a few reasons, one of which is to make sure that expectations are appropriate. Some of our devices require a trial before moving to the implant, especially spinal cord stimulation. That's a situation where we would place temporary leads under the skin and the patient would go home for 5 to 7 days with wires coming out of their skin, bandaged, connected to an external battery and remote control. So the patient can test out the device to see if it's appropriate for him or her. When the patient returns, we remove the wires in the office. It's not a surgical procedure, and discuss with the patient whether it was helpful, whether it was beneficial. If it was beneficial and reduced the pain enough and improved function, then we would make plans for the operation, usually a month later. We discussed the difference between some of the permanently implanted devices and the temporary devices. Healing time varies, of course, depending on what type of device is implanted. With a spinal cord stimulator, there's time to allow the patient's device to heal in place. So typically 6 weeks of restricted movement. With the temporary device that I discussed from SPR, people can resume activity within a couple of days. Therapy maintenance, I think, is a very important topic to discuss. With the pain that people have experienced for years and years, decades in some cases, they're hopeful and that they get treatment as soon as possible, and we go through this procedure, this process, and the expectation, of course, is to feel better right away. However, with neuromodulation, sometimes it does take time, and it does take reprogramming with the representative from the manufacturer. So how the person feels the day or a couple of days after the spinal cord stimulator or peripheral nerve stimulator is implanted, that isn't necessarily indicative of how they'll feel going forward. Sometimes the patient's device needs to be reprogrammed a few times to optimize its benefit for the patient. Again, our role in the system is to help people who have had chronic pain issues. If it's a surgical issue, I fully endorse having our surgical colleagues address the problem from an anatomic standpoint. If the patient is not a candidate, if the patient has had surgery and there's still pain, that's when Dr. Vucetich and I can perhaps help. To conclude, we have many new technologies, and to echo Dr. Vucetich, neuromodulation has come a long way just in the last 3 years. In fact, in the last year, one of the manufacturers in particular just made great strides in their technology. And in a sense, even though neuromodulation has been around for more than 50 years, I still believe it's in its infancy. Where we're going to be in 3 years and 5 years and 10 years from now, I can't even begin to imagine. If you would like to speak about this further, or if you have any questions for us now, please let us know.
Right. I think we do have a couple questions here. First question is, could neuromodulation help osteoporosis? Dr. McIntyre, would you like to take that question?
Well, I don't believe it's going to successfully address the issue of osteoporosis. That would be a condition you'd want to discuss with your primary care doctor. And in some cases, some other medical specialists would get involved. If there is chronic pain as a result of osteoarthritis that becomes neuropathic in nature, most of our treatments would not interfere with the treatment of osteoporosis and would not worsen osteoporosis. So many of our patients do unfortunately have that, but can still be treated with neuromodulation.
That's great. And I can give you a good example. I have a patient who has pretty significant osteoporosis and suffered compression fractures of her spine and multiple compression fractures. So everyone in the lumbar spine, and has left her with significant pain and multiple surgical consultations. But because the quality of her bone is weak, she's not a candidate for any type of surgical fixation or stabilization. So she's actually a patient who's going to be undergoing a spinal cord stimulator trial to see if we can help a large portion of her pain. Okay, next question. Does the implant stick out when you are wearing something fitting? So the answer is yes and no. So there are devices, and some of these implants are just a wire with no battery attached to it. Dr. McIntyre had mentioned that some of these systems, there's an external source, and they are getting tinier and tinier. But for the most part, the systems that have an internal battery, it looks like a small stack of, I usually call it a double stuffed Oreo, typically about this big, about this thick, and it looks just like a pacemaker if you've seen anybody. And Dr. McIntyre and I too do a good job at hiding them the best that we can, but depending on how thin you are, again, you may or may not see the device itself. Okay, moving forward, can chronic migraine sufferers be treated successfully with neuromodulation? Dr. McIntyre, would you like to tackle that one?
That's not been an indication, but that could be something that could be studied in the future. That's just not something that I've seen any success with at this time.
Okay. Let's see. Could this help my son that has spina bifida with chronic low back pain that pain medication does not help? So actually, Dr. McIntyre and I both have patients who have congenital deformities such as this. And again, it takes, sitting down with a specialist like us, looking at MRIs and really truly understanding where that pain generator is coming from. And so when we get a good understanding, then we can apply one of the other, as you can see, there's a bunch of these different types of devices and therapies. So the answer is yes, it could, with the right pain generator, absolutely help a patient who has a congenital pain condition. Can you use this if you have a defibrillator? Dr. McIntyre, would you like to handle this question?
So this is something we'd have to have a conversation with the cardiologist to make sure that the devices are not going to interact with one another. So, we've reached out to cardiologists in the past and have a conversation to make sure that it would be safe. There are situations where we can, and there are other situations where we cannot.
Yep, and we definitely both, Dr. McIntyre, have known each other for over 15 years and practiced together. There are certain instances, for instance, if your defibrillator pacemaker is up here in your chest, we don't want to implant anything close to the shoulder, put an energy source close to it. However, if we're tackling a knee or an ankle or even a low back, what we do is we bring people, from both representatives from both companies into the operating room with us, and we run the systems together to see if there's any interference. And we always take every precaution, like Dr. McIntyre says, to speak with the cardiologist who maintains the device before we, move forward with anything like that. So it's not an absolute contraindication. It's just to make sure that you take every safety precaution before providing one of these therapies.
I'm waiting to hear from a cardiologist right now for one of my patients.
Would a device like this help with a spine that has lots of arthritis? Dr. McIntyre, would you like to comment to that?
So there's actually a new device, a new peripheral nerve stimulator. I didn't mention this before, that addresses arthritis of the low back. What we've found is that a lot of people with arthritis in their low back not only have that as a source of the pain, but they also have atrophy of the muscles, the paraspinous muscles, the muscles that help support the spine. And in that situation, there is a peripheral nerve stimulator that's very new to the market, that has helped with this sort of atrophy and ultimately helps with arthritis of the low back. This is a situation where we would need an MRI. Of course, we'd have to evaluate the whole situation. So it depends on a lot of different factors. But to answer your question, yes, it can help with somebody with a lot of arthritis in their spine.
Excellent. Next question. Both of the tops of my legs get numb and tingle and have nerve pain. I don't have diabetes. Could this stimulation help with this? Absolutely. This is an ideal situation where just basically what you've told me in these sentences is that sounds like nerve related pain. And obviously, going to a specialist like one of us, we would kind of want to investigate where the root cause of that pain is coming from. Is it a peripheral neuropathy? Is it an irritated nerve coming from the spine? Is it an irritated peripheral nerve? And applying a therapy like this could definitely help with a pain area like this. All right, next question. Could this help with my shingle pain and shoulder pain? Dr. McIntyre.
Absolutely. I have implanted spinal cord stimulators for people with chronic pain from shingles, the postherpetic neuralgia that Dr. Vucetich mentioned earlier. It can be a fantastic treatment if gabapentin and Lyrica haven't helped. The blocks, unfortunately for shingles pain, are largely ineffective and that's been proven over and over again in studies. So if the medications aren't working and the pain is bad enough to warrant such a treatment, somebody could be a candidate for neuromodulation. As for the shoulder, patients have done quite well with shoulder pain where surgery is not indicated. Both Dr. Vucetich and I have implanted many of these SPR Sprint devices for people with shoulder pain, and the vast majority of our patients have done very well. And in some cases, we can implant the permanent devices as well. It just depends on the person's response to treatment.
All right, next question here. Can this be used to diagnose if the pain source is from the hips or the spine? And can it treat or break up a thick cluster of nerves? So that's kind of a two-parter. So, typically we consider a more advanced therapy. So in order to tease out where pain is coming from, whether it's coming from a joint or from the spine, Dr. McIntyre and I will use diagnostic procedures. So say a nerve block, a hip injection, a nerve root block, or numbing up where the nerves come out of the spine that might go to the hip. And so kind of teasing out where it's coming from, because as we kind of stated through the common thread is this treats nerve related pain. And so mechanical pain of the hip would have different treatment options. So again, we would probably use some smaller diagnostic procedures to really tease out that information. And then that would guide us, as to what other type of neuromodulation device could be helpful. And then as far as breaking up a cluster of nerves, this device would not be used to break it up per se. However, these peripheral devices that Dr. McIntyre we were speaking of, if there's damage to a cluster of nerves, and there's several clusters in our body, some of them are up here in our neck and some of them are down in the low back or around into the groin before they enter into the legs. These therapies can definitely be applied to those areas if there's a known damage to them and a pain that's originating from that damage. All right. Do spinal injections cause kidney failure, i.e. from the steroids? It's a little bit off topic, but you have two interventional pain doctors with over 25 years of experience, so we're happy to answer all these questions. Dr. McIntyre, in your experience, have you ever had or any issues with any kidney damage with epidural steroid injections?
So I have not, and generally we would not expect an occasional steroid injection to cause a problem. That said, if somebody is taking steroid daily because of a rheumatologic condition or a pulmonary condition, and then they're getting steroid injections on top of that, whether it's for their spine or their hips or their knees or all of the above, yes, we can run into some serious problems. But the occasional epidural steroid injection, we would not expect any long-term damage to any organ system. What I tell folks about steroid injections and the side effects of steroid with an occasional injection. What I mean by occasional is a couple of times a year, facial flushing for a day or two, a bad night's sleep for a night or two. Diabetics can have their blood sugar go up for a few days. The vast majority of what the steroid would cause would be very, very temporary. But that said, we're all different and we all respond differently to medications. So we do have to be cautious whenever we make the decision to treat somebody with a steroid injection.
Absolutely. Okay, this is a really great question. Can neuromodulation be used both before and after knee replacement surgery, including during physical therapy post-surgery? So, Judy, you bring up a really great topic. So this is a really new application of these peripheral nerve stimulator devices, specifically the one that we had mentioned that is only in temporarily. And Dr. McIntyre and I have used this device for patients. We implanted it about 2 weeks before a knee replacement was completed. And it was in through surgery. And then it was placed post-operatively. It was through post-operatively and through the 6 weeks of physical therapy. Now, again, this is a very new, novel use of this device, and it is being currently researched in clinical trial. But for the right patient, and I'll tell you, my patient had a history of opioid use and was just very adamant that she would not have a knee replacement if she had to have pain medication. And as if anybody has known anybody who's had a knee replacement, it is a painful condition. And so my N of one, my one patient that I've done, did have the opportunity to go through that entire surgery and rehab without needing any opioid therapy. Now, again, that's just an experience of one. That may not be the experience of everybody. And like I said, it is currently being studied in clinical trials. But it was a great experience for this patient, and we definitely achieved the goal. We had to work with the orthopedic surgeon, and we had a great orthopedic surgeon that was working with us that was willing to allow us to place this device. And we thought it out and we planned it thoroughly, and it was excellent. And Dr. McIntyre and I have also done it for shoulder, specifically rotator cuff repair. Again, we had a similar patient, and these patients did fantastic with it. So I think what we'll learn in the right patient, it's very appropriate. But we definitely, as a field, need to learn more about the application for acute surgical pain, because again, this could definitely change how we do things. Dr. McIntyre, our anesthesiologist by training. And so again, could these small devices be placed, shortly before surgery to provide, pretty significant pain relief and allow patients to heal faster? So more to learn from that topic, but a really, really great question. Next question. Do you need a stimulator for each area of your pain? Dr. McIntyre.
Well, and we'll go back up to the question above in a moment. I think we skipped one, but to answer the question about do we need a stimulator feature, it really depends. So we've run into scenarios where people have leg pain that's in more than one nerve root distribution, and the nerves are not close enough to treat at the same time. And yes, we've needed 2 peripheral nerve stimulators. That said, I've treated people with neuropathic pain in their hands and their feet, and was able to achieve stimulation for all 4 limbs with 2 leads in the cervical spine, 2 spinal cord stimulator leads in the cervical spine. So it really depends upon the scenario, but we should go up to the scoliosis question.
Oh, yes. Is it possible for this to help with scoliosis that went untreated? So again, there's a lot that goes on with scoliosis, and there's both a mechanical component to it, as there's a curve to the spine. It puts force, right? Gravity impacts us down on our spine. And if there's a curve, it's going to put force on the mechanics, the joints of our back, but it also can put force on the discs in our back and can cause something called spinal stenosis, or narrowing of the spinal canal and around the nerves. So again, that is it's how you kind of answer it is maybe, right? So I would make a consultation with a physician like Dr. McIntyre and myself, and kind of be evaluated and see if the pain that you're having could be treated by one of these devices. So the answer, I guess, right there is maybe, if the pain matches the need for therapy. Okay, here's another great question. My husband has chronic low back pain and scoliosis and dementia. Is this perhaps helpful? How much supervision would he need? I care for him at home. Dr. McIntyre, we see a lot of patients, and can you speak to how simple these devices can be for patients?
So it's very possible that it could be helpful. Just because someone has dementia doesn't mean that they shouldn't get treatment for their spinal pain. Both Dr. Vucenic and I have, several patients, unfortunately, who have dementia, and they deserve treatment as well. Some devices require a little more supervision. So, it depends upon the condition that we're treating. We would maybe steer away from the temporary device, because, it's really easy to pull that out in some cases. So maybe that would be a device that we would want to steer clear of, because it does require some care, and you have to be cautious to avoid pulling it out. But that said, sometimes spinal cord stimulation, we could still apply that therapy to folks with dementia.
Absolutely. And I'll tell you, our motto is that nobody's too old for treatment or to have a better quality of life. My oldest patient that I have implanted was 92 years old, and she had a little bit of dementia, but her goals were appropriate. She wanted to go to church on Sundays, and she wanted to go out to lunch with family on Wednesdays, and she had pretty severe leg pain from spinal stenosis. And the expectation was appropriate. And what the funny, cute part of the story is that when picking a battery, she said, "Oh, I don't want to recharge one. I will never outlive that 3-year battery." But lo and behold, at age 95, she did outlive the battery. And just over the summer, I had to put a new non-rechargeable battery in her, and her therapy continues to meet her goals. She can get out and be social, and it's very easy for her to use. And again, I think that kind of answered a couple questions. The next one's down. Does it help with stenosis? Does it help with degeneration of the spine, spinal spurs, and arthritis? And again, I think I'm going to keep going back. And Dr. McIntyre, I'm sure you agree with me. It all depends on the kind of pain that you're having, and can we achieve pain relief? And that really comes from a consultation, a really thorough investigation. And sometimes that may involve a diagnostic procedure to confirm that if we move forward with this device, that it'll be helpful for you. But yes, these are definitely common conditions that we use these type of devices to help treat patients, and specifically, patients who may not be a candidate for surgery, and because of their health or because of their age, and they have severe spinal stenosis. This definitely could provide a better quality of life. Does insurance cover this? Dr. McIntyre, you've been doing this a little bit longer than me. What would you say about this question?
Yes, of course, we would get an authorization beforehand, but yes, insurance covers. There were a couple of really good questions above I wouldn't want to miss. There's a question about having knee replacement twice, scar tissues causing severe pain, and your surgeon recommended radiofrequency ablation. I've done ablation for the knee, and I continue to do that. I still offer that treatment. I find myself, and this is because of patient response, offering the peripheral nerve stimulator instead. I think the treatment is more durable. It lasts longer. The ablation is fine. Again, I still offer that procedure. Dr. Vucenic, what is your opinion on that matter?
No, I completely agree. And, that knee ablation procedure was first published in 2011 and was really the go-to for both of us for almost the last decade. But again, like everything, medicine does advance, and and Dr. McIntyre and I have always kind of tried to stay on the edge, the curve of what's being presented, what's being thoroughly researched as an appropriate treatment and is not dangerous for our patients. And so is radiofrequency ablation effective for our patients? Absolutely. Your physician is offering you a very good therapy that has been researched. But I agree with Dr. McIntyre, in the right patient that's selected, peripheral nerve stimulation for chronic knee pain after surgery, or even dorsal root ganglion stimulation in certain cases can be a more durable therapy, meaning it's going to last longer. There is a limitation to radiofrequency ablation, whether it's 6 months, 8 months, 12 months, 16 months, but at some point those pain responses start coming back. And if we have therapies that can give our patients a little bit more longevity than that, we are starting to change and morph our practice and lean towards that. So yes, it could be great. Not an RFA and knee RFA is a wonderful therapy. We've helped a lot of patients with that. But this definitely could be an option for that treatment.
There's another question we missed, which is after a steroid injection in the cervical spine, I shook so much I couldn't work. Is this normal? No, it is not normal. Is it a side effect or an allergic reaction? It's hard to say with the amount of information given. I tend to think it's more of a side effect, perhaps, of the steroid than an allergic reaction. Steroid can cause agitation and it can be severe. Also depends upon how long it lasted. Hopefully it didn't last very long, but it can cause severe agitation in some folks.
Any application in labor and delivery? Not been studied yet. Epidurals for labor and delivery is pretty much all we have at this point. But who knows where research will go. Does a stimulator alleviate spinal stenosis? And it doesn't cure it, right? It treats it. So the spinal stenosis will still be present. We are treating the pain caused from the stenosis. So Dr. McIntyre and I are not spine surgeons. We do not go in there and make spaces bigger. We do not, people say roto-rooter, and then we hear those things a lot of time. We don't do that, right? And in some instances, patients don't have the option to do that. But what we can do is treat the pain from that condition to give a better quality of life. And the last one, do I need a referral to schedule appointment? You do not need a referral to schedule appointment. For us, sometimes insurance companies do require you to get a referral from your primary care doctor, but you can reach out to our office. Our information will be given to you, or the appointment line at University Hospital. You have a great network of interventional pain doctors. Dr. McIntyre and I are both trained at University Hospital and have taught there a long time ago. And you have a huge network of really fantastic pain doctors who can help you with these therapies and help kind of tease out where your pain is coming from and lead you really down a right path to a better quality of life.
Okay, we actually have one more question for you. An attendee asked, are steroid injections into the hip the only alternative after physical therapy and chiropractic treatment?
Dr. Vucenic.
So yeah, so again, it's technically, we're assuming that this is for osteoarthritis of the hip. And there are some procedures. We had mentioned about a nerve burn or a nerve ablation procedure that can be performed on the hip. There are a couple sensory nerves that we would bring you in and we would do a diagnostic block to see if your pain would go away for a short period of time. Obviously, neuromodulation, right? We put an anesthetic on a nerve and we affect it. And if your pain did go away for a short period of time, then we technically can do an ablation on that to get some pain relief for you for 6, 8, 12 months. However, ultimately, a potential hip surgery replacement, arthroscopy would ultimately be the option, pending on your health and the opinion of the orthopedic surgeon.
Okay, thank you so much, Dr. Fusetic and Dr. McIntyre, for your time and sharing this information and answering all of the great questions from our audience. I just wanted to give the attendees a couple of reminders. We will email you a link to view this session on our website once the recording is posted. To schedule an appointment with a UH provider near you, please call 216-844-3771. This concludes tonight's session. Thank you for attending and have a good night.
Thank you.